It's a challenge that policymakers face. And even though financial inclusion or ensuring that every Indian has access to money, whether it's loans through state-run banks or insurance, has been a mantra for the government, a lot more still needs to be done. And nowhere is the need as much as in basic healthcare. Insurance here can protect millions and ensure that a simple illness does not mean bankruptcy, as often is the case. For Kiran Mazumdar-Shaw, one of the best-known names in the Indian healthcare sector, healthcare insurance is an important and crucial cog in the wheel to ensure that the best of healthcare reaches all.
It's a very difficult and complex subject and question. Health insurance was never seen as a standalone vertical. So typically when you went to the PSU insurance companies, who were not standalone health insurance companies, they bundled health insurance in. So when you bundle something in, you are not pricing it mark to market or not pricing it to cost. So that set a very, very low table for health insurance pricing. So typically these insurance companies who price their products based on not actuarial, not realistic, not market-based data and experience, found that 100% of the time the claim was more than 100% of the premium. There can be no business model, because the fundamental of insurance is that hopefully on an actuarial basis over 10, 20, 30 years, the claims are less than the premium, and that margin or surplus is really what gives you the return in the insurance.
And the sustainability.
And the sustainability. Now that wasn't happening because 100% of the time the claims were higher than the premium. So when these standalone health insurance companies, or Sahis as we call them, came into the market, they started to price health according to the specific product. What are we delivering? What are we offering? What is the likely price and cost of that based on some projected actuarial basis of claim profile, if you will. So therefore, the private health insurance companies are charging more premium because their pricing is more realistic relative to these, may I say, at the cost of being sounding critical, the fuddy-duddy, public sector non-life companies who also do health. So a huge shift and adjustment is required. That means that firstly, these PSU general companies, non-life companies, I think should exit that space. And with more private health insurers coming in, there should be market-based pricing. And in this country, with the private life insurers coming in, there's such strong contest that you are getting best-in-class service, best-in-class product, very, very aggressive pricing, and so on and so forth. The same thing needs to happen in health insurance. Frankly, I think more should be left to the private sector. I'm not calling it public-private partnership. I'm calling it more government-private cooperation. And if government would listen to the private sector, I think if there are just 2 things or 3 things the government did, that is a favorable land providing policy, because land is too expensive at market rates for healthcare providers to acquire. Urban, it's practically out of bounds, but even in semi-urban and some rural areas, that's one area. The second area where government can help is encourage private sector to come in for medical education, for building training at schools for wellness professionals, allied health professionals, nursing professionals. Once that supply side goes up, the cities will decongest, the doctors will want to go and work in the semi-rural areas. But so long as the education
the human
resource is constrained, this shift is not going to happen. Of course, we can always go back to the finance ministry and ask for tax breaks and ask for some concessional soft loans and 30-year, 40-year money at some concessional, interest rates for borrowing and so on. I think those
are mechanistic kind of issues.
But that's where the problem is.
हमारे मालेगांव तहसील के ग्रामीण इलाकों में प्रशासकीय आरोग्य यंत्रणा काम न करने के कारण गांव और कस्बों के लोगों का आरोग्य धोखे में आ गया है.
म्हणजे ते प्रत्येक प्रकारने गोळी पाहिजे, प्रत्येक प्रकारने इंजेक्शन पाहिजे. आता त्या येलो होत्या त्या डॉक्टरीन बाया तिसले विचारायला लागू म्हणतो सर्दी व्हायची लहान पोरगाले त्या गोळ्या आम्ही आणल्या नाहीत म्हणे. मग तुम्ही काय चहा पाणी करायला वाण्यात का म्हणतो एवढापर्यंत बोलून अजून
सरकारी डॉक्टर खाजगीमा होतात का? त्या
मग खाजगी दवाखाना बिशात ना त्यासनं आला
स्पेशल दवाखाना बिशात
मी पुरावा मिशन आम्ही त्या तोंडवर सांगतो ना तिथे जर कधी मोठा काही रेकॉर्ड काहीच आहे
दवाखाना इथून किती लांब?
इथून कळवाडीस येतो.
सरकारी खाजगी कसं?
मग 16 किलोमीटर.
जो तो प्रत्येक मग दवाखाना लांब असल्यामुळे खाजगी डॉक्टरकडनं इंजेक्शन वगैरे घेतात आणि तात्पुरती गरज भागाडी घेतात.
आरोग्य कमिटी नाही,
अजून पंचायत आरोग्य कमिटी नाही, काहीच नाही, कुठेच काही नाही.
तुमले दरवर्षी 10,000 येतात त्या कथा
ते कुठले आजपर्यंत तुम्हीच आमले प्रश्न विचारले आहे ना 10,000 येतात आमले माहितीच नाही, जनतापर्यंत कुठलीच सुविधा नाही.
They should be able to get comprehensive, free, publicly financed and publicly provided health care. In practice, people have to pay quite a lot out of pocket to get any health care, and it's often the main source of health care, even for the poor.
A major problem in the public sector, lack of government funding. Total expenditure on health per capita is $109. Compare that to $7,290 in the U.S. Healthcare consumes 4.9% of India's GDP versus 16% in the U.S. The outcome, long lines, fewer facilities, and inefficient staff.
Villagers in eastern India are sick from drinking contaminated water. It's a problem for many in rural India due to a lack of clean water sources.
Villagers of the Ladakh district of India's Jharkhand state have fallen sick after drinking contaminated water from nearby wells. Many people have developed diarrhea while some have died. No official numbers are available.
There are 150 hutments and the villagers are not so cautious about their health. They are drinking contaminated water from the wells and are falling sick. Many have died.
Local doctors have tended to the sick, but the problem of contaminated water is yet to be addressed. Contamination of large numbers of drinking water sources is a serious problem in the rural areas of Ladakh. It's mainly due to unsanitary conditions around the drinking water sources. An estimated 88% of diarrhea deaths worldwide are due to unsafe water and poor sanitation or hygiene. India has the highest number of annual diarrhea deaths, more than 386,000.
The mission of Project Rishi is to bring healthcare and social outreach to areas of India that are in need of it. These areas of India are usually rural, and they usually don't have access to a lot of the more developed infrastructure that we take for granted over here. And as a result, they need a lot of help in terms of development, both socially, healthcare-wise, and economically. If you were to walk down the street of the village, you would see just rows of shanty huts and basically cottages just lining both sides of the street. On both sides of this road, you'll just see children, kids, everybody just playing, and you know, everybody, if you're a foreigner, you'll walk down this road and everybody will just stare at you. Sanitation is a big problem over there. So you see these sewers that are just covered with all sorts of debris, you know, waste. Access to healthcare is a big issue. There is a government clinic that's a couple kilometers away, but it's so understaffed right now and it sees so many patients that I felt, as well as the rest of the group felt, that it was necessary to build this clinic. Project Rishi is about applying what you learn over here in school about problems concerning, you know, the world and, you know, the global stage on a real, you know,
एक सिर्फ मैं आपको आंकड़ा देता हूं शुरुआत में, बाकी बात हमारे एक्सपर्ट्स जो हैं वो करेंगे कि इस समय हिंदुस्तान में लोग खाने पीने के बाद अपना सबसे ज़्यादा पैसा जो खर्च करते हैं वो हेल्थ केयर पर करते हैं. वो पढ़ाई पर नहीं करते, वो अपने ट्रांसपोर्टेशन पर नहीं करते, फैशन पर नहीं करते, फिल्मों पर नहीं करते, हेल्थ केयर के ऊपर करते हैं. और ये संख्या कुल 2,65,000 करोड़ के आसपास 2014 में हो जाएगी. अगर हम देखें तो यहाँ पर टेक्नोपैक के आंकड़ों के हिसाब से, और इसमें हर साल 10 से 12% की वृद्धि लगातार हो रही है। तो एक बहुत बड़ा गैप हिंदुस्तान में जो इस समय है वो मौजूद है।
He may have left medicine for politics, but he has stayed back in India, awarding degrees to AIIMS graduates. Health Minister Anbumani Ramadoss spoke out against the exodus of doctors to greener pastures abroad. A research conducted by a Delhi-based NGO shows that on an average, more than 60% MBBS doctors passing out from AIIMS go abroad looking for work. And it's American soil which beckons them. 87% head for the USA. In 2008, the Planning Commission estimated that there was a shortage of 6 lakh doctors in the country. The report also stated that the doctor-to-population ratio stood at a dismal 60 doctors to 1 lakh people. The health minister's plea to young doctors that they should practice in India as there is an acute shortage of doctors in the country stands out in sharp contrast to his decision of not extending the tenure of 183 senior resident doctors at AIIMS. These doctors now claim that the only good enough option before them is to go and practice abroad.
It's a very unfortunate thing. We want to work here because patient care should take lead much over personal rivalry and other form of politics.